Hello everyone, and welcome to this lecture on diuretic drugs. This is Professor White. Diuretic drugs are any drugs that accelerate the rate of urine formation. So remember, our kidneys are the ones that make urine, and when we do urinate, what are the contents of pee? What do you think? What's in urine? Certainly water, but also electrolytes, and sodium and potassium and even calcium. So basically, diuretic drugs increase the rate of urine production and the removal of sodium and water and some of the other electrolytes from the system. We use diuretic drugs to treat things like high blood pressure, heart failure, and even renal failure. My favorite organs are actually the kidneys. So let's take a quick peek at what the kidneys do. Basically, they are hugely important to maintaining homeostasis. They are obviously part of the RAS system with renin and angiotensin and aldosterone. They are responsible for filtering and responsible for basically metabolism and excretion of certain medications and other substances. They also are the gateway to preserving those important substances. So if we have functioning glomeruli, it keeps all the proteins where they should be by not letting our protein go into our urine. And the functional unit of the kidney is called the nephron. So here we have a picture which is a cross-section of a kidney, and you can see the nephron within the kidney, and we have a little blow-up picture of one nephron, and then we have the glomeruli in there. So the glomerulus is of course important. It's where the afferent arterioles and the efferent arterioles enter and exit into the area here. And in the nephron, we have some very important areas, right? So we have the proximal tubule that is right behind where the glomerulus is. So we have the proximal tubule. And down here, we have the descending loop of Henle, and then the ascending loop of Henle. We follow our nephron all the way up to where we have the distal tubule, and then the collecting duct, and then eventually the urine is sent to the ureter and to the bladder. And based on the location of where the medications work in the nephron is how we classify them. So we do have several different drugs that we use that are diuretics. We have our osmotic diuretics, carbonic anhydrase inhibitors, the loop diuretics, the thiazide diuretics, and the potassium-sparing diuretics, which all work at various parts of the nephron. And so you can see that in the Lilly pharmacology book. There is a really good picture of the nephron. And just a nice little picture here to show us, I'm sorry, it's not a picture at all, but just some conversation here about those different areas. And remember, our diuretics are classified according to their sites of action with the nephron, their chemical structure, and their diuretic potency. So you can see what happens in each area of the nephron. Most of the sodium and water that our body will retain is pulled back into the bloodstream in the proximal tubule. The loop of Henle has about a quarter of the sodium reabsorbed there. The distal tubule is where the rest of the sodium is reabsorbed, and aldosterone is in charge of that area. And then finally the collecting duct. And this is just a graphic of the different types of diuretics that we have. And not pictured here would be in the center, but that would be our fluid balance. That is the star we're looking for to make sure that we maintain adequate fluid balance. So the first group of drugs we're going to look at are the carbonic anhydrase inhibitors. These are the medications that end in zolamide. So if you see, sometimes we have medications that we treat glaucoma with. Those are some of the more common carbonic anhydrase inhibitors. So brinzolamide, dorzolamide. So again, those are for treatment of glaucoma. Acetazolamide is one that the patient will take for basically for heart failure and fluid balance. We'll take a look at the indications for these meds next. All right, so these meds are used for glaucoma, open angle, increased intraocular pressure. So you see I have two eyes there, two eye indications. They're used for the treatment of edema. They're used for the treatment of heart failure and high altitude sickness. So those may all be indications that you might see. Here are some of the contraindications and cautions. So the carbonic anhydrase inhibitors, they are actually a derivative of the sulfa drugs, that class of medications. So there is some talk about an allergy to sulfa and the understanding that there could be a cross allergy here. Now, science isn't really bearing that out, but it is something to always recognize as a potential. Hyponatremia, hypokalemia would be reasons that we would want to be very careful and maybe even contraindicated. Severe renal or hepatic dysfunction, so if our kidneys aren't working well or liver's not working well, and cirrhosis kind of leads into that hepatic dysfunction and any adrenal gland insufficiency. All right, so here are some of the more common adverse effects of the medications here. So the carbonic anhydrase inhibitors. So acidosis is listed here, hypokalemia, renal stones, drowsiness. You can certainly read all of these. One of the other things is that they do elevate blood glucose levels, and they call glycosuria, especially in our diabetic patients, right? And because they induce metabolic acidosis, their effectiveness diminishes in 2 to 4 days. So all of these are possibilities. There are several drug interactions, so careful use with digoxin, as this can potentiate toxicity, especially considering the hypokalemia. If you use this with corticosteroids, this can also cause hypokalemia. And then it can also increase the effects of these medications that are listed here. So amphetamines and phenytoin, carbamazepine, those are definitely anti-seizure medications. Cyclosporin, quinidine. So just medications to be aware of, that there are definite interactions with this class of meds. So as we move on to the loop diuretics, this is a fan favorite, if you will, very commonly prescribed. Most everybody that I know of that I take care of in the hospital with a diagnosis of heart failure has these medications on board. Usually furosemide or Lasix or bumetanide, Bumex. So those are the most common ones that I've used in my career. And they do work on the loop of Henle, so that's how they get their name, as they are loop diuretics. So loop diuretics have a pretty rapid onset of action, so they're very useful when we have a desire to have rapid diuresis. They do have an advantage over thiazide diuretics that even as renal function and creatinine clearance kind of drops, that these medications remain pretty effective. They can be given in IV form, and at least some of them. And the onset of action is really within 15 minutes. When I give furosemide to a patient, they start to pee almost immediately. So they do, again, work directly at the loop of Henle. It inhibits the sodium and chloride reabsorption, and also has a little bit of effect on the prostaglandins. So dilates those vessels. So very, very useful in the treatment of edema and when we're trying to get fluid off of a patient. So these are very commonly given in an IV form for a patient who is in decompensated heart failure. As we said, the diuretic effect is marked in here, and you can see I have my patients who really have to go to the bathroom as a result of it. So be prepared. If you give this intravenously, your patient will have to go to the bathroom and rather quickly. But at the end of the day, it does result in a reduction in the blood pressure, decreases the pulmonary vascular resistance, so those vessels, total systemic vascular resistance, so it drops the pressure that way as well, and decreases the end diastolic pressure, so it takes some stress off the heart, right? But some of the issues that are with this one, of course, is that with sodium, potassium is also lost, and that can spell big trouble for our patients. And also the diuretic effect, we can definitely take off too much fluid, and our patients can be left with a deficit, so they may be more on the dehydrated or dry side. That can be problematic. Patients who are more likely to experience these effects are those, of course, who are elderly, higher risk for falls coming out of this sort of thing. So keep that in mind, that the desired effect can also have some other issues with it. So here are some of the indications as well. So we use it to treat that fluid retention that's related to heart failure, or sometimes there are other disease states, kidney disease and liver disease. It treats high blood pressure, hypertension. We use it to help excrete calcium. So remember, the calcium is also an electrolyte that can be excreted by the kidneys. We also use it to increase urine output and excretion of other things that we may not even think about right now, but like in gout. So if somebody is not able to excrete their urine, that would be a good reason to give it. For all the good that these drugs can do, these loop diuretics, they also have some pretty important adverse effects. The patient may become dizzy, may have changes in their hearing, tinnitus, blurred vision. Torsemide can cause Stevens-Johnson syndrome, hypokalemia, which can become life-threatening, hyperuricemia, right, which is interesting. Didn't I just say that we could use it to pull out the uric acid? But again, with fluid volume deficits and some issues, we could end up with higher levels of uric acid and also hyperglycemia. All right, some of the interactions that we had here. They do interact with the aminoglycosides, which can cause increased neurotoxicity. Taking these with steroids and digoxin can sort of make more additive hypokalemia. So hypokalemia increases the risk of digoxin toxicity. NSAIDs can cause a decrease in the diuretic activity of our loop diuretics. And thiazide diuretics, right? When we start doing sequential nephron blockade, they will have an additive effect of the diuresis. So that's why sometimes you'll be giving a couple of these different classes of meds. It's because of that sequential nephron blockade, right? So just be aware of that. Some of the other things is that you may have increased hyperglycemia for those on anti-diabetic drugs because it decreases the effect of those drugs. All right, so the prototype loop diuretic that we're going to look at is Lasix or furosemide. Lasix is named so greatly because it lasts 6 hours. So it is the prototype loop diuretic. We use it for all different reasons that we may want to remove fluid from a patient. Everything from edema from heart failure to nephrotic syndrome, people with ascites. It is related to the sulfas, and there may be a little bit of cross allergy there, so just be aware of that. It is available IM, IV, and PO. But with the fluids comes electrolyte loss, and it does cause significant fluid loss. And as a result, remember, furosemide can cause orthostatic hypotension, which is why a lot of times we have holding parameters on this medication. Because of it being such a potent diuretic, we also recommend that it be taken in the morning so that it doesn't keep your patient up at night and make it so that they can't sleep because they have to pee constantly. All right, so the next class of drugs that we have to talk about are the osmotic diuretics. These work with just as the name implies, osmosis, by pulling the water into the tubules from those tissues surrounding it, causes rapid diuresis. Again, this is not for our normal use of somebody with heart failure. This is used for intracranial pressure issues, cerebral edema. Of course, it should not be used if we have an intracranial bleed. Some of the adverse effects here, we have seizures, pulmonary congestion, and thrombophlebitis, right? So usually you'll see it in use following any sort of head trauma, potential craniotomies, brain surgeries, things of that nature, where it would be ideal to decrease the intracerebral pressure. The prototype osmotic diuretic is mannitol. This is available for IV use, infusion only. It is given in critical care areas. And you can see here this crystallization. So that happens if it's exposed to lower temperatures. So many places do keep it in a warmer. Must use a filter because of that possible crystallization. We wouldn't want to have those infused into the vessels. And again, can cause severe cardiac or renal impairment. It is not available orally, okay, only by IV. So now let's move on to our potassium-sparing diuretics. Of these, they actually work on aldosterone. They're just known as potassium-sparing because of where they work in the nephron. Most common that I've given is probably spironolactone or aldactone. And the thing that you should take away from these potassium-sparing diuretics is that when we're sparing the potassium, that can allow potassium to build up as we change the fluid balance. All right, so here's your mechanism of action. So it works in those collecting ducts and the distal tubules and interferes with the way that sodium and potassium exchange, blocks the aldosterone. So it keeps sodium and water that we would normally have it be reabsorbed. It blocks that, but it also prevents the potassium excretion. The exemplar potassium-sparing diuretic drugs are listed here. We have spironolactone and triamterene, and they treat more than hypertension. They treat more than heart failure, but definitely they are used for people. Imagine they have too much potassium loss from the loop diuretics, that this would be more indicated for them. But again, as we're retaining that potassium and keeping the body from excreting it, that leads to other problems. Amiloride, I can't say that I've ever given that as a nurse or seen it on a medication list for my patients, but we should be aware that it does exist, and that's the class it belongs in. All right, so here's your adverse effects. Certainly you can figure out what they might be. They are diuretics, and diuretics in general do have the same sort of adverse effect profile. Maybe not as much orthostasis here. However, we are still diuresing patients. Aldactone, on the other side, does have some specifics to it, which we should be aware and share with our patients. So gynecomastia, amenorrhea, so that would be development of breast tissue, loss of the period, so they wouldn't potentially have a period or might be irregular, or postmenopausal bleeding. All right, some of the major interactions we have here. So if you have these potassium-sparing diuretics with lithium, can cause lithium toxicity. Signs and symptoms of that are generally GI disturbances. Increased hyperkalemia with those ACE inhibitors. Once again, taking potassium supplements can also lead to hyperkalemia, and NSAIDs can diminish this response, so just like it was in furosemide. I want you to be very mindful of the potassium containing aspect of many of our food choices, and many of our patients who are on cardiac diets because they have heart failure are given these seasoning packets like Mrs. Dash and such, and those are actually pretty high in potassium. So let's teach our patients about things they might be doing because they think they're healthy, but can actually be worsening hyperkalemia. All right, so we're going to start talking about the thiazide and thiazide-like diuretics. So most common thiazide diuretic you're going to see is hydrochlorothiazide, also often abbreviated as HCTZ. And our thiazide-like diuretics, so they're very similar in structure and mechanism of action. So metolazone, chlorthalidone, and then one that seems a little weird there, but indapamide. So according to the folks who make the rules about what we should be giving for patients in heart failure, they once again are recommending thiazide diuretics are among the first line drugs for the treatment of hypertension. And I believe in our hypertension lecture, or one of the other lectures, we talked about the ethnic considerations for our thiazides. All right, so the mechanism of action here, these guys work on the distal convoluted tubule. Basically lets the patient excrete water, sodium, and chloride, potassium, but not to such a huge extent. So it's not very common we would need any sort of replacement on these medications, though always possible. And also dilate the arterioles, right, by directly relaxing them. So this is what makes it a highly favorable profile for medications. And although there's a diuretic effect, it's not as strong as something like furosemide, but the effects are here for you. So it lowers the peripheral vascular resistance. We do deplete sodium and water and potassium as a result, just not as much of an extent as our loop diuretics. They don't really continue to work very well if the creatinine clearance starts to fall below 30 to 50. However, metolazone does continue to work, so you'll see that still on long after kidney function has sort of diminished a bit. All right, some of the common indications that you'll see for these thiazide-like diuretics and thiazides. Hypertension, by far and away, biggest indication that we see it for, though you will see it in the treatment of edema, whether or not it's related to heart failure or not. Too much calcium in the blood, diabetes insipidus for more chronic, all right, because acute diabetes insipidus, that's dangerous for our patients. We really need to treat it a bit more aggressively. And then, of course, it's not a mainstay treatment for heart failure, but it is something that would be added on for management and also for cirrhosis. All right, we start to see sort of the same signs and symptoms of the adverse effects to this. Once again, dizziness, headache, blurred vision. This one, and has the added bonus of impotence, potential jaundice, and leukopenia, or decreased white blood cells. So that tells us that we need to monitor liver function and our CBC for our white blood cells. Other things it can cause, hypokalemia, so low potassium, high blood sugars, high uric acid, and then hypochloremic alkalosis. So that would be very rare, but just understand that it is always a potential. All right, some of the meat and potatoes about taking care of patients who are on diuretics in general. All right, we want to have a baseline fluid volume status. One of the best indicators that we have for fluid status is our intake and output and the weight, right? So check their blood pressures, make sure they're not orthostatic, make sure your patient doesn't have contraindications to the treatment. Have the patient take their medications in the morning if possible. Diuretics are better tolerated during the day than at night, though I know sometimes people are in pretty bad heart failure. They have to take a dose in the morning and in the evening. We recommend that they take those doses still kind of earlier in the evening if possible. Monitor their potassium levels and make sure if they're on digoxin that we're monitoring for increased potential for digoxin toxicity. We need to have them on a potassium-rich diet if they're on the potassium-wasting medications, and a low potassium diet if they're on potassium-sparing. So some foods that are high in potassium include things like oranges and bananas, dates, apricots, raisins, broccoli, green beans, potatoes, meats, fish, beans. So the legumes. If your patient is diabetic, you need to monitor their glucoses. Make sure you have your patient know the importance of coming for their follow-up labs and make sure they're scheduled. All right. If we start a patient on furosemide, that is potassium wasting. The expectation is that the potassium will go down. We don't know how much until we test them. Understand that our patients may experience a fluid volume deficit because of these drugs, especially old folks. They may lose electrolytes and as a result start to have signs and symptoms of the lost electrolytes. So think about the signs and symptoms of hypokalemia. What does that look like? What is the signs and symptoms of hyponatremia, hypocalcemia? All right, let's continue. All right, and we need to make sure that the patient is monitored for the therapeutic effects. If your patient is taking this for edema, did they have a reduction in their edema? If they are taking it for heart failure and fluid volume overload, we want to have them to be euvolemic, EUVOLEMIC. That means of a good volume. We don't want them hypovolemic, and we don't want them overloaded. So remember, we look at patients' fluid volume status with their weight. Patients should be taught to take their weight daily and let their provider know if they're gaining more than a couple pounds in a day or 5 pounds in a week. All right, they should be watching their intake and output. There really is, as our daily weights, really best reflection of status. They should be improving in their signs and symptoms of heart failure. If they're on it for hypertension, then we should have a reduction of the blood pressure, understanding, of course, that we can always swing them the other way. We don't want our patient hypotensive. We want them normotensive. And if they are on any of the drugs for increased intraocular pressure, then we would want those pressures to return to normal. So that is that. All right, everyone, I want to thank you for sticking with me as we delved in some of the diuretic medications that you'll be giving as a nurse. And hopefully you've enjoyed it and learned something. And I'm leaving you with this cute little cartoon about water weight. So thank you. Have a great day.